type of virtual. In order for there to be, the meeting is being recorded. In order to have any kind of remote participation or any kind of virtual capacity for meetings, and a public body has to have some kind of policy in place. So that's what we're kind of trying to get through at this meeting, if possible, if you all agree to what we're putting in front of you. So there's this document here that's kind of a rundown of what we are proposing for the policy based on some guidance that came out from the FOIA Advisory Council on how to implement these policies. And just to kind of give you like a high level review of what the legislation requires and how this policy kind of meshes with it. There are two different types of meetings under the new legislation. There are meetings that there are in-person meetings that have a physical quorum, but where there are certain options that members can participate remotely. And they can still, if they're approved to participate remotely in those types of meetings, they can still vote, they can, participate in the conversation and be officially counted as present. But they have to have one of a set number of excuses that are enumerated in the legislation. And the policy that a committee establishes can't be more permissive than that legislation, but it can kind of further refine what is in the legislation. So if you look under A, those items 1, 2, and 3 are the exceptions that we're proposing to include in the initial policy. And so there would be exceptions for a member who has an illness or who has a family member who has a health condition of some kind that need to be able to participate remotely for that reason. And then the other reason would be if a member joins the committee, or if one of you at this time lives more than 60 miles away from the location where the meeting is being held. So those would be the allowable exceptions. Yeah, you can just turn it on. And then the other type of meeting is an all virtual meeting, and that's a meeting that doesn't have to have a physical location. If it does, that location has to be physically open to the public, but it has to have electronic participation by both the public and the committee members. And those are limited to 2 per year for a committee that meets with the frequency that CHIPAC does. So that's the maximum. And in the policy that we have drafted, we would have the maximum number. So it'd be 2 meetings a year, and they would be non-consecutive. They have to be non-consecutive. So it would have to be like, what is it, March and June, or December and I don't remember. It would have to be every other meeting. And so those are the basic high points of this policy, and happy to answer questions. And also, I guess, if folks have suggestions or would like to have input on this today, we can certainly do that. But there will also be other opportunities. So we'll put this on the agenda for the CHIPAC Executive Subcommittee meeting in October. And folks can either let Sarah or myself or one of the other executive subcommittee members know if they have input or strong feelings about any part of this they think should change. And folks are also welcome to attend that meeting. The executive subcommittee meetings are always open to any of the members to attend, and to members of the public as well.
So if anyone has any questions, let us know. Take a second to review it, and then if you are okay adopting this today, and we would just need to vote.
Sorry, quick question.
Oh, go right ahead.
And I apologize. Is In the code, isn't there like a personal exception?
Yes, okay.
And I'm sure there's a very good reason why it's not
Yes,
included.
no,
but-
I'm sorry. I didn't mean to be non-transparent about that. So there is an additional exception that we've not included in this draft policy for CHIPAC, which is a personal reasons exception. That would be limited to 2 meetings per year. We did not include that because the committee already has under the bylaws, there is not any consequence for a member's membership in the committee unless they miss 2 consecutive meetings. So if we have 2 all virtual meetings per year that are non-consecutive, that situation isn't really going to be likely to arise. And members also have the ability to send a substitute in their place to the physical meetings, in which case they're counted as attending under the current committee bylaws. So
And when we looked at it, the member would have to like provide with specificity why they were missing the meeting, and that it felt like we had enough, kind of based on what Hope said, like other ways around that where you don't have to provide with specificity or personal reasons, to like me and Hope.
Yeah.
That would be the goal, yeah.
And I guess my only then further question, like selfishly for me. So if I can't make it, am I still allowed to watch?
yes,
Okay.
so yes, and
know I can't vote.
and we have some members today who, even though the committee doesn't have a policy in place, they're watching as members of the public today because we don't have the policy. So that will continue going forward. If there's an in-person meeting, it's not an all virtual meeting, and someone wants to join remotely but doesn't meet one of the criteria to do that officially as a committee member, you can certainly always tune in and listen in as a member of the public, because it is required, or I don't know if it's required, but we will be having all of these be electronically available. The link will be up on Town Hall and the member will be getting the materials.
But that still counts as an absence, right?
It would still count as an absence.
So you can
That's
send
right.
a substitute potentially, and then also watch online yourself if you wanted.
Yeah, and Sarah, you have a copy of the bylaws. You can pass that around if folks want to look at the current bylaws. Section 9 is what would be changing, but that has the information in it about like meeting attendance. It has the policies about meeting attendance and what's required.
Thank you.
Can you remind me, and we're going through this at BDH as well, so I apologize for asking this question, but with all virtual meetings, can you vote during all virtual meetings?
So for the all virtual meetings,
If we were to
anybody
have
can
one.
vote, and the conversation, it's just as if it were in person. And then for the remote meetings, if somebody's permitted under the rules to participate remotely and they've gotten permission and everything and followed the procedure, then they can participate just as if they were in person. If they don't meet those criteria, but they're just tuning in as a member of the public, then they can't have those member privileges.
We're navigating.
Yeah.
Okay.
FOIA guidance is very helpful.
Would substituting the word medical condition with a more umbrella term, I'm trying to think something that would encompass, other conditions like a dental, or, I mean, I would assume mental health falls within medical, but dental sometimes is considered separate. Injury can or cannot sometimes be, so something more umbrella, like maybe health or something like that, or is there a specific?
Two things I would say, I'm sorry to interrupt. 2 things I would say about that. This is the language, I think this mirrors the language of the code. And for these medical exemptions, as well as for the remote, for the principal residents more than 60 miles away, they're unlimited.
Sure.
The person can participate remotely an unlimited number of times for those. So, and we're reflecting that in this policy and not limiting the number of times. Those personal exceptions, where you do have to say, well, this is what happened, I got a flat tire, and that has to go in the meeting minutes and be recorded. There's a limited number, it can only be 2 per year. So I think if we scoped the language too much from what it is now, it might kind of become a personal exception that would be limited instead of being a health exception. I will say that.
Instead of medical. Could we say health instead of medical?
Let me look at what the,
It seems like that's more of an umbrella term.
I think it's probably fine. I can look at what the code says, but I would, the person doesn't have to disclose the specific medical condition either to Sarah or myself. And it doesn't have to be in the minutes. It would just be like the member has a health, a health related exception.
I feel like health, I mean, I'm not thinking about it for myself. I mean, by the way, I live 60 miles away.
Yeah.
See you guys, and I'm just kidding. I'm just kidding. But so it's not really for me. It's really thinking ahead for like somebody who's new, who isn't going to have this conversation, who hasn't, who sees themselves there and then feels like, whatever their need might be at some other point.
Medical condition is sort of an older term. We are
Yeah.
broadening things and thinking more of overall whole person health.
And we are
rather-
children's health insurance
Exactly.
advisory.
That's a good.
Very good point. Not children's medical.
Do we need to bear, or
My only concern with that is that that is the exact language of the code, and I would say we would interpret that broadly as anything health related. But maybe my preference would be to leave it as it is, but at the committee, it's the committee's decision, so that's something we could put up for a vote to change that language.
And what's the consequence of diverting from the?
So if you have a definition that mirrors the code, the agency counsel, the attorney is likely to approve this policy if there's discrepancies in the policy and an issue is raised, they're going to always rely on what's in the code. So it should reflect what's in the code. I will say medical condition is a very broad term though. A dental condition would fall under that, or a behavioral health condition.
Yeah.
we can vote or we can not vote. I mean, as a committee member, you can, if you would like to vote, you can certainly say that. And again, it doesn't have to be-
Remember, I'm not gonna be here,
it doesn't
so
have
I'm
to
just
be
kidding.
closed, so, no one's gonna be questioning either.
Shelby, I think it's a good point too, though. We're overdue for a new member orientation, and I think the committee has had almost like full turnover since the last time we had one. So one of the things that we can highlight at that orientation is that when medical, by medical, we construe this broadly to relate to things like dental and behavioral health.
This is partly bringing me back to the whole SimSip days to, check, so, where we mess with terminology quite a bit. So anyway, but thank you for thinking.
You don't need an orientation, Shelby. You've been a member for longer than I've been staffing committee.
Sarah, is the goal to have it approved today?
The goal is to have this approved today with the knowledge that it can be changed at any meeting. But in order to be able to host virtual meetings and have people have the ability to attend virtually at our next meeting, we would need something.
Well, I'll make a motion to approve this.
May I ask a question first before we move on? In number 3, that's specific language from the code as well. Just because, I prefer to attend in person as well, but even though my residence may be less than 60 miles, my principal place of employment and these meetings are during the course of the day is much more than 60 miles.
As the legislative representative from the government, I would only speculate that the focus by the bill drafters was on legislative members coming to committee meetings, and that's probably why the language was that way, but I've been going through this simultaneously with Hope because we have to establish it for our commission, and sadly, that is specific code language. So I'm not a lawyer, but I think we'd be on shaky footing by inserting place of business.
I just wanted to ask.
Well, and if it becomes an issue, we can add in the personal exemption. And so if that becomes the thing that the committee wants to adopt, we certainly can do that. I think for Hope's point, like we thought we had enough flexibility to remove it and remove the kind of overall situation of me having to like pry into your life and be like, why are you missing this meeting? I have 2 kids, I don't need more, right? Like, then we, you know, if it's, I live 59 miles away, we have 2 virtual meetings, ability to attend the other 2 virtually, and these set exemptions don't let me do that, we can add that back in.
And I'm sorry, I didn't read the whole thing carefully. I know that there's something when the entire committee would meet virtually, like if there was an emergency, including like, well, I don't know what would happen
Well, so
with
there
snow.
are 2, we can have 2 all virtual meetings a year.
Okay,
And they have to be decided beforehand to be virtual, because it needs to be like publicly posted that
Sure.
way. And they have to be non-consecutive.
okay. My question
They
is,
don't have to be during an emergency. It's just on.
okay.
Do you mean, are you talking about a like a public emergency, a state
So
emergency?
I was just going to ask, because I didn't read this whole entire document. So what I was gonna ask is, in the event of, and I know that you can ask for a personal one, but like, let's say in DC or in Northern Virginia, whatever, it's snowing, and it's dangerous to come, I could use a personal one and wouldn't be embarrassed to put it in the minutes to say that that's the reason. But then what happens if, anyway, I think it could get tricky. Like there could be some issues that could pop up where people might find themselves. So I think having a policy that's as kind of forgiving and, an understanding that people are doing the best they can kind of thing is best, but I'm not sure, how that might be reflected in this. Or if there is a way, if there isn't, then we just have to do our best.
It can be included in the minutes if it can be included that a member was not counted as participating, but attended the meeting. So that could be reflected. I don't think that we would go into the detail about the circumstance if we didn't have the personal exemption in the bylaws, but.
And I didn't read through the FOIA, sorry, is there guidance in the FOIA, like in the case of an emergency, state declared emergency?
Yeah.
Have more than 2 all virtual in a year?
Right, so there's a separate, and Jeff probably has probably looked at this section more closely than I have, but there's a separate section for what happens if there's a declared emergency and what the allowances are for virtual meetings in that context. This is all about non-public emergency situations. And so, but in the instance of, DC area, I think in that case, there would be the ability to do the principal residence exception for some members if they were affected by something where they lived that was outside of the Richmond region.
Yeah.
So it seems to me kind of like, it's sounding like 2 options on the table. One is just to vote and accept it as is for right now. The second would be to vote to add the personal exemption back in and then vote on that as the policy. We can read what that language would be, maybe. I hope I think it's on the.
I can read what it says.
Or we can vote on this as is, and the executive subcommittee can look at that language and bring another draft to the next committee meeting with the personal exemption in it. And that way we'll have the language to look at.
Yeah, I feel
That's fine.
Yeah. Okay, so
So just, if we do not vote on it today, that means that the next meeting will be like this one that we will have.
So
have to
We are
have.
I would recommend that we vote on this.
Oh, okay.
Executive subcommittee will look at the personal exemption language and we'll bring another draft, including that language to our, so just so we have something in place for next meeting. And then at that next meeting, we'll have a second draft with that exemption in, and the committee can vote to either keep this or adopt the new one with personal exemption.
It's current draft.
A second.
All those in favor? Anyone opposed? Great. Thank you all for that, and you can definitely get that added in, but I appreciate that we now have the flexibility for the remote option and remote participation for next.
Sarah, may I ask just a kind of a related question? Not specific to the remote meeting policy, but is UMass, this location going to be the future home of our meetings? I know we used to not meet here. I, for one, would prefer not to meet here, but
The location where we used to have the meetings isn't available anymore. For the foreseeable future, we're planning to have them here. We're gonna go ahead and book these meeting rooms for 2023 once the committee has approved the dates. Just because it does have that hybrid setup that if, we're doing 2 all virtual meetings per year, we could still have a physical location as long as it's open to the public. So we would probably continue to run 2 kind of hybrid type meetings per year, similar to what we've been doing. And we have the capacity with, all of the AV and everything to do that here. That said, we're open to input on that. And I would say just reach out to me or to Sarah or to the executive subcommittee, and they can discuss that further to the extent that we're finding that a lot of the members are having challenges with parking. I mean, I know that there are hardships involved, and it's kind of just finding the best solution that works for everybody. Also, if you have ideas of other places, the executive subcommittee would be happy to entertain that. So.
So our next item, and I think final item on CHIPAC business, is just voting on our meeting dates for 2023, which are up on the screen right now. Along with that, I kind of wanted to also float the idea of since all virtual meetings do not be consecutive, we tend to have shorter times in like summer and then holiday right before session time. So having June and December at least be penciled in as the virtual meetings. Well,
No, I agree. Yeah, based on, we don't have a long session this week, so I'm just thinking. So yeah, that makes sense for me.
okay. Just so executive subcommittee members know, the same virtual policy would apply to subcommittees, that you get like a second round of 2 virtual, this is 2 virtual meetings, so it's not cumulative, it's separate for each subcommittee.
And you don't have to do it that way, I don't think, but
Whatever.
that's what this policy states. We've approved.
Feasible on that.
Yeah, so I don't know if anyone wanted a minute to check calendars. If not, we can just entertain a motion to vote on the meeting dates for 2023.
Move to accept the proposed 2023.
Those in favor?
Aye.
Anyone opposed? Great, thank you all so much. We are 2 minutes ahead of schedule. Nice work, everyone. Yeah, we're gonna turn it over to Dimas. So as we mentioned at the end of last meeting, the theme for this meeting is our behavioral health for our kids in Virginia through the Medicaid and CHIP program. There's been just an immense amount of work in this area over the last several years. And so we're really excited to have folks read Dimas tell us what has been happening, as well as share some of the new data transparency tools around behavioral health.
All right, I'm not sure who is starting us off. Is Dr. Ward or Dr. Aplaska on the line?
No, it is me, Laura Reed.
Oh,
Good
Laura, I'm sorry.
afternoon. I hope. And I am joined by Dr. Aplaska from BBHCS. She is here with us this afternoon, as well as Ashley Harrell, another behavioral health senior program advisor here at DMAC. And Dr. Ward may or may not join us via phone. She is in the car traveling back from a conference in Pittsburgh, so she may or may not be able to join us today. Good afternoon, everyone. Thanks for having us. We're excited to tell you, give you some updates about everything that our team has been doing, including our collaboration with BBHCS. And Brooke, if you could go, you can skip actually the next 2 slides and go to slide 13. There you go. We're going to give some updates on our Project Bravo project, which is the enhancement of our mental health service array. And also Ashley is going to give some updates about our arts benefit. And we're going to talk also a little bit about how our division is going to be moving forward this year around really integrating our mental health and SED services. Many of our Project Bravo services actually provide service to those with a primary diagnosis of substance use disorder. And a lot of people do not know that because, of course, it's in the Mental Health Services Manual. So why would anybody think that? But it is really important to us to be integrating those two things in terms of policy and program, but also within our division. So we're also working to really integrate our divisional tasks, and so not have individuals just be working on mental health or just be working on SED. So we're sort of going to be going over the next year and a transformation of our own in our division as well. And then we're going to talk about our Utilization Dashboard, which our division collaborated with our Office of Data Analytics and our contractor Optum to get that up and running. It's been up and running for a couple of months, and I use it on a daily basis almost, and I'm excited to show you everything that it has to offer. We'll probably take some pauses for questions as we move forward in case anybody has any. So, or can you go to the next slide, please? So I wanted to start off the presentation by just giving some really basic data points about where sort of Virginia lies in terms of overall data and overall sort of prevalence of mental illness. And so what you're looking at is some data from Mental Health America. It is the 2022 data, but that data is based on 2018 and 2019 data. And what you're looking at is the red is the national average, and the blue is where Virginia is, and these are percentages of prevalence. And so the first category is youth MDE. MDE stands for Major Depressive Episode. And so this is the percentage of youth that are reporting a major depressive episode. And as you can see, really with all the categories, we're very, very close to the national average. And when I looked at the data this morning, I have to say, many of us think that Virginia is like way down on the list, and in some things we are, but to be honest, we're sort of smack dab in the middle for a lot of these things, which of course we could do better and need to do better, and that's what we're working towards. But at the same time, we are definitely not way, way down at the bottom any longer. So that's really also nice to see that we're making improvement. In terms of ranking for prevalence of major depressive disorders, we actually jumped. We were at 26 last year, and now we are at 20, number 20 of all 50 states. And the lower the number goes, the better it is. So that's exciting that we're making progress. So the first category is youth reporting major depressive episodes. And again, we're really close to the national average, which is around 15% of youth reporting major depressive episodes. The next category is youth MDE, which is a severe major depressive episode. And we're a little slightly bit higher than the national average, which is around 10% of youth reporting, and we're right around 13%. The next is adults reporting any sort of mental illness. And again, we're right around the national average. The national average is around 19%, and Virginia is right around 18% reporting of any mental illness, and this is adults. And then for the adult SUD category, again, we're very almost smack dab right on the line with the national average, which is around 7.75%, and we're right at 7.3%. And then youth reporting substance use disorder, we are slightly less, which is a good thing. The national average is around 4%, and we're right around 3.7%. So that's just a little bit of where we are in terms of overall prevalence and how we stand up to the national average where we are. So can you move on to the next slide, please? So the next slide is specific data from the National Center for Health Statistics. It is 2022 data. It is looking over time, over the last 2 years. It is this is adult data, so it does not include children. And percentage of adults who are reporting symptoms of depression and anxiety during COVID. And we are at 28.3% of adults reporting symptoms of depression and anxiety. And you can sort of see that there's this little red star on the slide where the average is of the entire United States, and then broken out by all 50 states. And the more percentage, which is sort of on the Louisiana side, and then we're sort of on the lower side, which is a good thing. So I just wanted to just give sort of an overall impression of where we are in terms of prevalence. And now we're going to give you an update about our Project Bravo services, and I'm going to hand it over to Dr. Aplaska.
Thank you, Laura. So I'm Alyssa Ward. I serve as the Deputy Commissioner for Clinical and Quality Management at the Virginia Department of Behavioral Health and Developmental Services, and I serve as our agency's lead for Project Bravo. Dr. Ward and I started at the state around the same time, about 4 years ago. And then at that time, Bravo, it's just a thought. And so it's come a long way in 4 years in the middle of a pandemic to put together and work with community partners and lots of experts across the state to develop a continuum of care for Virginia, Medicaid, and of course for the rest of Virginia as well. And so we put those things to paper. We built out those services, and then COVID hit, and we had some bumps along the way in a very, very rapid time frame to begin implementation of these services, which began just over a year ago on July 1st of 2021. We focused on building out the highest levels of care in the system because we recognize the need to meet people where they are. And right now, we have a lot of people in mental health crisis who go to emergency rooms, who show up in primary care, who show up in the state hospitals because there are no other levels of care below it that can immediately meet their needs. And so the 6 services that comprise phase 1 of Project Bravo are Assertive Community Treatment, which is essentially a hospital without walls for individuals with SMI. This is a team of people who go out and meet people where they are to provide psychiatric, social, and therapeutic care. Intensive outpatient and partial hospitalization are both intensive facility-based types of programs for youth and adults. And then in our second phase of that, as of December 1st, was multisystemic therapy and functional family therapy, 2 youth-based, highly evidence-based therapies that are for community and families. And then, of course, our comprehensive crisis services, which have been in the works for many years prior to this implementation. It intersects with a lot of needs of Virginia, including the build out of Step Virginia at our community services boards, who are the backbones of the crisis services, and the safety net for all of Virginians, and have limited tools to provide that. In the DOJ settlement agreement, which largely serves individuals and focus on individuals with developmental disabilities, who also experience a lot of crises and need an alternative to being placed into highly restrictive settings. And so while it looks like there's only 6 services here, I usually tell people we have embarked on 9 new services in the past year, which is a huge, huge feat for our teams, for the state, because crisis services is made up of also its own continuum of 4 distinct services. Mobile crisis response, which are people coming out to the community to meet you where you are in the middle of a crisis. Community stabilization, so sort of this longer term need for crisis stabilization beyond that immediate response. 23-hour crisis, because there are some crises that just resolve within less than 24 hours. It's need time to know what resources are available out in the community, and then residential crisis stabilizations, which are sort of intermediate or step down from a state hospital or inpatient level of care. So we had a lot of accomplishments in this 1 year and these past several years in the implementation. The MCO partners are the service delivery mechanism of these services, and many of them had shortened timelines to half of the time that we had anticipated because, again, of COVID and the delays related to funding and the budget freezing in the middle of COVID. And so they've been incredible in terms of stepping up to the plate to know that these services are needed. We've also maintained a lot of close partnerships with behavioral health associations and provider associations. And this is important because these are the individuals who are actually delivering the services on the ground. So all the changes that we make are truly felt by them. Every line item change that we make and every dollar that we change is intended to help the provider. And then the development of the Center for Evidence-Based Partnerships with VCU. And this is acknowledging that we needed a center where and technical support where providers would learn about evidence-based practices, because that's what we are trying to build upon. We have a lot of services in our Medicaid space that were conceived 20 years ago and really need to catch up with all the research, best practices that we've learned. And this is where VCU is really helpful with that. We've also had a lot of challenges. So while our General Assembly and our state has really invested on providing and delivering the services, we've had very little training dollars, which has hampered the ability for the workforce to deliver the new services. That, coupled with COVID and a lot of people leaving the behavioral health workforce, didn't really do us any favors in sort of creating this robust entry into these services as we had hoped. The thought was that as we build services that have high evidence base, we would attract high quality mental health workers, more of them into the state, because as Laura had highlighted in her first couple of slides, we do have a mental health access problem in the state. We're ranked among the lowest for mental health access, and particularly for youth mental health. So we are trying to kind of address both the workforce and the limited training dollars. And not just workforce, but the complexity of the crisis infrastructure has really also kind of delayed the impetus that we've had in building it out. It is a high demand service, and it is a complex system of care that people are providing and needing. Not a one-size-fits-all approach. And so we've had this intersection, as I mentioned, with the code mandates at the state for Virginia at the CSB level, with the Marcus Alert program, which requires engagement and coordination with law enforcement, and then these 4 new services, which are brand new, and this never-ending pressure on the state hospitals to be available to serve and meet the bed of last resort legislation. And then lastly, and probably one of the most monumental things of our time, is the rollout and implementation of the federal 988. This has been a long time coming, and the integration with that has been aligning with this work. Next slide. So what comes next? We have a lot of service learning collaboratives to continue to build out. The crisis system, as I mentioned, has so many moving parts and complexities that we really need to be attentive to. We also want to measure how we're doing, what we're doing well, where we need to continue to put forth efforts, and that's where metrics and evaluation come into play, and anticipate any unforeseen negative impacts, as well as highlight all of the positive impacts we were anticipating from building out these services, and then explore those opportunities for expansion. So some things might start off small, and we really need to think about how it expands across the state and where certain disparities might be. Next slide. again, with the future direction, so we're barely out of the gate with phase 1 of Bravo, and we are always getting questions about what's next. We know that while we implemented a lot of services that are targeted for youth, it doesn't necessarily encompass their comprehensive needs in a continuum sort of way. And so the COVID-19 pandemic has further highlighted the impact of the youth mental health needs because of disruptions in school, disruptions in services that were previously operated in group and really focused on the social environment of youth. Those impacted a lot of services like therapeutic day treatment, which were provided in schools, provided in group settings, which they could not do during the pandemic. And then the identification of needs within the schools and those opportunities related to providing care within the schools themselves. And then the need for kind of wraparound services, and particularly the high fidelity wraparound model, which is a case management model to connect kids with high needs to much needed care, and then the coordinated specialty care, which is a program for first episode psychosis. The other thing that we know is happening is that youth are presenting in large numbers to primary care clinics in non-traditional mental health spaces. And so our pediatricians and family doctors are becoming the front line to address mental health challenges. And so we've continued to build upon and expand on the Virginia Mental Health Access Program, which is operated by the Medical Society of Virginia through State General Fund to partner pediatricians, primary care doctors, nurse practitioners, family doctors with child psychiatrists to train them how to identify early mental illness in youth, begin treatment, and also be a lifeline to calls. If you're in the middle of the clinic and you have a kid in front of you, that you have a phone number to call and phone a friend and a colleague to say, you know, am I doing this right? Would you be doing the same thing? Should I start this medication? And give you the reassurance that you're doing what you can with the tools in front of you. And then on the other spectrum, we also know that there is a need to integrate care into long-term care spaces, especially for our aging population and the geriatric needs. COVID again has highlighted the need for that because of the restrictions that unfortunately to keep their health and safety related to COVID in mind also resulted in some isolation of this population, sort of disconnected from their youth, and saw a lot of mental health impact related to that. Next slide. Crisis. Crisis is the safety net to the safety net to the safety net. And this image is great because it has a fence, which should be providing that safety net, and people falling through and somebody right there to receive them. The model that we've decided to pursue here in Virginia is called the Crisis Now model. And this is a model that has been shown to have a lot of evidence and very robustly built out in the state of Arizona. And the model has really shown us data that with a robust infrastructure for crisis and multiple layers within a crisis system, that there's actually very few people that actually need to go to hospitals for care. So when we have a robust system, and that includes a call center, they've shown that approximately 80% of crises can be resolved through that call center. So just calling 988, talking to a mental health professional on the phone, and then having that crisis resolved then and there. And of those that don't, 70% of mobile responses can be resolved in the community. So avoidance of emergency rooms and avoidance of hospitalizations, and really just meeting somebody in their home or in a place where they feel comfortable that can be provided support in that moment of crisis. And when you have all of those layers, what happens is a very small proportion of those initial calls actually result in hospitalization, which is what we want to see. The next slide. So the objective was to develop a community-based, trauma-informed, recovery-oriented crisis system that prevents out-of-home placements. And so what we have here, those components are the high-tech crisis call centers, the 24/7 mobile crisis response, crisis stabilization programs, and these guiding principles and practices. So this really firm culture and belief that we want to serve people in the community, divert them from emergency rooms, and make sure that they have access to the least restrictive care that meets their needs. Next slide. So what does this look like? So a lot of people describe the 988 phone number to 911. And while it's similar in that it is 3 numbers, it's actually very different in that the person that you reach on the other line of the 988 phone number is not just a dispatcher. This is a trained mental health worker. They are able to answer questions, provide resources, assess for suicidality, assess for those types of risks, and then either one of these 5 options would happen. So that crisis could be resolved by that person on the phone, that single phone number. It could also result in a dispatch. So unlike 911, so similar to 911 where they dispatch an ambulance or fire department or police officer to where you are or what you need, they could do that here as well. They could connect you with an existing provider. They could connect you with other services, or they could result in an escalation in care. So continue to be in contact with who they dispatch you to understand where you ended up going. So if they sent out mobile crisis dispatch and they decide that you do need to go to the emergency room, all of that information is there. Or if you end up in a crisis stabilization unit or 23-hour, all of that information is in that hub. Next slide. So this is the continuum of care that we are working towards. This is our North Star, that we have this stepwise progression to all the other services here in Virginia, that, you know, after an acute or crisis, mental health crisis, that you're stepping down into the next level of care that meets your needs, and not just sort of being left to figure out things on your own. What we also know is that a high portion of the individuals that are served through the mental health system have high rates of co-occurring substance use disorder, from 30 to 50% in some settings. And so I will pass it on to our next presenter, Ashley Harrell, who will talk a little bit more about the integration of those art services into this.
Thank you, Dr. Oplaska. So we could go to the next slide. Also, I want to take a moment, and I do believe our division director, Dr. Alyssa Ward, may have joined the room. So just wanted to give her a moment to acknowledge that she's with us, and also invite her to chime in as needed. So I wanted to point out to you, of course, I'm Ashley Harrell, and I work with our substance use disorder benefit at Medicaid. But in case you haven't seen it, the Virginia Department of Health puts out quarterly fatal drug overdose reports, and just recently posted one in July. And it does show that the fatal drug overdoses for all substances increased by 15.5%. in 2021 compared to 2020. I think the trajectory is that the amount that it's increased over time, we're seeing some improvements, but we still have work to do. Medicaid is also the largest payer for substance use disorder treatment nationally. And about 40% of individuals with an opiate use disorder are enrolled in Medicaid, and that's primarily due to Medicaid expansion. So I'm saying that just to share with you, Medicaid has role, just as Dr. Oplaska said, around our mental health system, but we also have a significant role with substance use disorder treatment. And something that we learned is that when Medicaid, because we're such a large payer of behavioral health services, when we transform, not only does it help Medicaid members, but it also helps commercially insured and Medicare because we're transforming the system. So as we have mentioned earlier, researchers have found that about half of individuals who experience a substance use disorder during their lives will also experience a mental health disorder and vice versa. We have common risk factors that contribute to both substance use disorders and mental health disorders. They run in families. Genetics can be a factor, but also environmental and trauma experience can impact individuals' experiences with mental health and substance use disorders as well. This slide tells you a common list of co-occurring disorders that accompany substance use disorders, and then also just the importance that we need to be able to treat both. Because a lot of times individuals that are experiencing one will have experiences with the other. Next slide, please. Before we go into that, we can stay on this slide, but I also just want to point out some additional data. The Centers for Disease Control reports that by 12th grade, about 2/3 of students have tried alcohol. About half of 9th through 12th graders have used marijuana, and about 4 in 10 9th through 12th graders have tried cigarettes. And I just want to point out to that kind of, I don't know why that shocked me, but more 9th through 12th graders have tried marijuana than cigarettes. So just kind of leave that there. We've also, the CDC reports that 12th graders report 2 out of 10 have used a prescription medication that was not prescribed to them. So other risks associated with substance use among teens include the impact on brain development, association with other risky behaviors, including unprotected sex, dangerous driving, as well as contributes to the development of adult health issues if they continue using or not addressing substance use disorder or mental health, including heart disease, high blood pressure, sleep disorders. So we know that the earlier that we intervene, the chances of individuals developing substance use disorders and additional mental health issues later in life are somewhat reduced. So that being said, I want to then kind of transition to this slide just to talk about some of the Bravo services that address both mental health and substance use disorder treatment services. As Dr. Oplaska said, we have the Assertive community treatment, which is a team-based treatment delivery. As she mentioned, it's referred to as a hospital without walls. ACT is a highly coordinated set of services that is offered by a group of medical, behavioral health, and peer recovery support providers who work as a team to address the complex needs of individuals who have severe and persistent mental illness. Something that ACT is also able to do is to work with individuals that have certain risk. It may be for hospitalization, homelessness, substance use, victimization, and incarceration. And ACT does require a team member that is a substance use disorder specialist that has the ability to treat co-occurring disorders. Next slide. And so now we have 2 new services, multi-systemic therapy and functional family therapy. These are intensive family community-based treatment for adolescents, and they address externalizing behaviors of youth with significant clinical impairment and disruptive behavior, mood, and/or substance use. MST and FFT are integrated in our mental health services manual and the intensive community-based support appendix. And youth must have, they may have a diagnosis of substance use disorder that's primary, or they're at risk of involvement with the legal carceral system. And then just some more stats on substance use among 12th graders. Next slide, please. So with the comprehensive set of crisis, I had a couple additional slides. Let's just jump to crisis services. So as Dr. Plaska mentioned, this is a full set of evidence-based crisis services that includes regional call centers to dispatch public and private providers to conduct a multiple crisis intervention, ongoing community-based crisis stabilization, and that we also would provide appropriate reimbursement for crisis stabilization units. These are our residential crisis stable units, also including 23-hour observation beds. And I'm going to pause. Dr. Plaska, Dr. Ward, and Laura, please chime in if I'm missing something. But really what I wanted to point out with these crisis services, and this is real time, I can tell you probably a matter of 20 minutes ago, I provided the 988 number to a coworker who asked me about her son who is experiencing a crisis, who is uninsured, so doesn't have the availability to be able to go to a private provider. And I can just tell you, it was nice to be able to provide her with that resource and know that it's available and it's not dependent on the locality and resources of that locality. So just that very mindful that this is a very needed service. Also wanted to point out in this slide, crisis response may be the only opportunity to help someone that is experiencing a mental health crisis, but also has a substance use disorder. Nearly 38% of people living with a substance use disorder have a mental illness, and those dependent on alcohol or drugs are 10 to 14 times greater the risk of suicide, with roughly about 22% of suicides involving alcohol intoxication. So this is critical, I think, for individuals that are in crisis. And also this last bullet point, just to share that eventually our goal is to have our mobile crisis response teams being able to, each team to be able to specialize with addressing individuals that are intoxicated or have a substance use disorder. And that both of our 23-hour crisis stay and our residential crisis stabilization units are equipped to treat individuals with a primary substance use disorder. With that, I'm just going to pause. Any other additions around the crisis services that my colleagues would like to interject?
This is Alexis. I just wanted to clarify also that none of these services related to crisis exclude any provider's ability to provide services regardless of diagnosis. The way that crisis is intended to work is that the individual in crisis describes the crisis. So if they feel like they're in a crisis, whether or not you or I would think it's a crisis, that is what drives the treatment and the level of care. And we just want to make sure that we are enhancing and continuing to enhance the services at these sites and these providers so that it matches the needs. If it is a substance abuse related crisis, that we do have trained substance abuse treatment specialists that can be there, or peers that can respond with them who have been through something similar, but it certainly doesn't necessarily say that this is a substance use crisis. We don't have anybody right now. We can't respond to this. And so I just wanted to just make sure that the model is really driven by the person experiencing the crisis.
And I will jump in too. This is Alyssa Ward from DMAS, and I'm off camera because I am driving home from the SAMHSA Region 3 988 Comprehensive Crisis Summit in Pennsylvania, and I'm just full of ideas and thoughts about these crisis services and their applicability across all diagnoses and all self-defined crises right now. I wanted to add in, just this note for this group, because I know that CHIPAC members are often, have their eyes on the data, very keenly interested in using that data to help guide us towards, best service for our members. And some of the data coming out from other states that are further along in their implementation is really, really powerful, and with specific populations. So looking at different ways to do crisis for different populations in terms of system coordination, but also finances. So for example, there's many different ways that crisis systems are organized and then data is collected. For example, Washington State is another managed care state for Medicaid, and they actually have carved out crisis services onto their own. And that is the way that they are able to kind of move and act very swiftly around those services because they are managed through a single entity. So there's a lot of different ways to do it, much in the way that some other states carve all of children's services out on their own. So we are learning and really actively seeking wisdom and feedback from states that have gone before us, because we appreciate the role that crisis plays across the lifespan, but particularly assuring that we have crisis services that are developmentally appropriate, that can serve kids and families. And the types of metrics that we're really looking to drive on this, coming behind these other states, is we want to see what they have seen, for example, in Arizona, of just a significant reduction of emergency department boarding for kids and families. These stories that we hear that are very upsetting for all of us when we hear about what
I think this is Dr. Ward going around the mountain. We have lost her.
Virginia.
Alyssa, I think you're breaking up.
Handcuffs and a TDO for hours and hours and hours away from their family and natural hard work of this comprehensive crisis. Can you hear me now?
Yes. I think, yes.
Where did I cut out exactly in my many words? I guess I would summarize to say that we want to end, youth being in TDOs far away from their families and emergency rooms being boarded. We don't think that should ever happen under any circumstance. And this is the kind of change that we are going to need to drive those metrics downward, to drive, the number of TDOs at all for children downwards, is, having them never have to enter an emergency department when they're not going to get that care there anyway. We want it to be in their communities with their families to stabilize them and to connect them with services. And so anyway, that is the long-term vision. And I'm just very excited that we're on that path, and ask for your grace and your patience as we work, to really calibrate that vision and build it together with our providers and our stakeholders.
Thank you, Dr. Ward. I want to pause here before we move on to the dashboard to give a chance for people to ask questions if they have them.
Hi, this is Ali Farouk. I have a few questions. I think while you guys were talking about Project Bravo, you mentioned that some of the challenges were the lack of funding for training and some workforce issues, which I suspect also are related to maybe compensation or funding. So my question is that, are any of the agencies putting that into their budget requests? Are leadership going to ask for more resources for training and workforce? Because I don't see a successful systems transformation unless you're actually talking about how the providers get there, whether that's the therapists or the physicians or nurses or peer support specialists, whatever that is.
What we can say from DMAS, this is Dr. Ward on the phone, is that we agree that there are many resources needed, but we are not at liberty to speak on the priorities of the Commonwealth at this time.
Okay. I mean, I would just say that perhaps that's the role for us as a CHIPAC to put forward recommendation. Thank you.
Thank you.
The only other piece I would add there to that is that, what we initially put forward for training of the workforce for Project Bravo is very different in this environment related to COVID. We were already in a very tenuous state of maintaining the mental health and behavioral health workforce in Virginia. And because so many people have left that particular frontline workforce, it is a different strategy that we have to really think through. I think a lot of people talk about rates a lot as a driving factor, and we're realizing it's not enough, right? The whole strategy is needed. We've at DBHDS, just sort of speaking from the experience of the state hospitals and the Children's State Hospital, CCCA, they were fully staffed when COVID hit, and they got hit by a pandemic. They were still taking very highly acute individuals, and the state hospital for kids has not recovered in the way that some of the other adult hospitals have. It's a 48-bed hospital that, as high as we've gotten in the past 2 years in terms of staffing, is up to 20 beds. And for most of the pandemic, we were as low as 10 beds. And we threw all the money that we had towards recruitment, retention, and there was just nobody coming. So I think we just have to think about those strategies a little bit differently. I appreciate the question, and you're right. We can't do the system transformation without the people.
And most of the crisis is non-hospital. So
that's right.
This is Emily from Voices for Virginia's Children, and I just want to ditto everything that you put up there as the challenges on your challenges slide, because that is something that we've been hearing from folks in the field and providers across the state. And I would add one other potential bullet to that list is really not only training in evidence-based practices that the Center for Evidence-Based Practices is really around, but also just training in implementing these new types of services as part of the continuum and what is available as part of the continuum. We find that because so many of these changes have happened in the COVID time period, and and simultaneously, that providers in public and private systems are just kind of unaware of all that's available to be able to take advantage of for folks. And I think that's one component of the system that we always find that one sort of historical observation that we're making is that over the last 10 years we've implemented a lot of new services, particularly for kids, that are really great, but we kind of miss the mark when it comes to implementing them and getting them in everybody across all of the different systems, from social services, CSBs, schools, private providers, to understand now across all these different systems, here's what's available to you. And so would love to have some more attention or some resources within the state government to be able to really help folks across these different systems, working with kids and families, understand what is available to them now and how to access services. So I don't know if that's training, care coordination, navigators, some combination of those things I think is potentially what could be looked at in this case too.
Emily, this is Dr. Ward. I just wanted to say that I couldn't agree more. I think we definitely need to add that bullet, and wanted to say that I think DMAS would love to have conversations about some partnerships with entities like Voices and other advocates, and thinking of ways that we can get out there to do large events now that we're back to doing more outreach and actual events like the one I'm driving back from, where we can bring people together to do more kind of systems training and orientation to not just what we've launched so far, but what we're trying to build, like really building. I think we're at this point where we're really needing to refuel the shared vision. I feel like we had that before COVID. We had done a lot of work together, all of us, in developing this shared vision, and people were generally, I felt, on the same page. There really wasn't opposition to Bravo going in. I think that it's now about, you know, coming back together now that we are actually physically coming back together, and, you know, talking like we are today about where we're at now, and then really pushing that vision. And like you're saying, tools to help case managers, care coordinators, you know, hospital systems, advocates, in understanding where these new providers are, where they can locate the services, how they access them, who's appropriate for them, all of that work. So I think that we've got a lot of work ahead of us, but
That's how I feel.
to start up those in partnership with you.
Yeah.
And
Yes,
this
and
is
I think, you know, what you're speaking to, so I did it. So by background, I'm a child psychiatrist. I am a trainer also for VMAP, and have trained pediatricians on mental health. And, you know, one of the things is that on the ground, providers don't know that these services have come online. They are busy seeing and providing care, that it is really hard as an individual provider to know that there's a whole new crisis system that's out there, and we can definitely do better in terms of letting people know that these services are there to be used. So I definitely agree there.
And this is Susan Brown. Sorry, I'm just curious what the general public knows about these crisis services. I think we've heard a lot about the 988 number, but as a suicide prevention line, the fact that it's really a great place for families to access this as a first line for crisis, rather than just going to a hospital, and understanding that there is this broad and integrated system now available to families might be helpful too.
Well, thank you everyone for your comments and feedback and questions. We are always here, and you can always get in touch with us through our divisional email box, which is enhancedch@dmas.virginia.gov. If you have any more questions or feedback, I am going to, Brooke, if you could go to the next slide, we're going to transition to talking about our dashboard, which I'm really excited to show you all. Oh, actually, sorry, Ashley, you have 2 more slides.
I do. I didn't know. Do I have time to highlight them for the group?
Of course.
Okay.
Sorry about that.
I will make this quick. So this is kind of unrelated to the crisis services, but I wanted to make sure this committee had this information. Wanted to give a shout out to our Support Act grant team. This was a team that worked with the funding that we received from the Centers for Medicare and Medicaid Services. Was close to $5 million to increase substance use disorder provider capacity in Virginia. And one of those was we were looking at priority populations, and so working with individuals who are pregnant or parenting with substance use disorders was a priority. And so one of our co-workers, Adam Krevling, helped to create a one-pager around peer recovery support specialists. So that is a goal for our division, is to increase access to peer recovery supports for individuals with mental health or substance use disorders. And this was focusing on peers who are also mothers. So we created this one-pager. And I just wanted to highlight what Adam pulled together around pregnant and parenting women are a unique population, disproportionately affected by substance use disorder, and they require tailored services instead of a one-size-fits-all approach. Gender-specific options operationalized within the peer recovery support benefit. These mothers with lived experience and in recovery can be the link and the safety net to others who are already experiencing some of the similar issues. And so wanted to point out that I think somebody brought up earlier being able to address this across our providers, but other stakeholders that are in this space. So it's Department of Social Services, early intervention, hospitals, prenatal healthcare providers. So that's a good resource, and we have the link there for you. And then I also wanted to point out, we have contracted with Virginia Commonwealth University for our independent evaluator for the arts benefit, which is our Medicaid substance use disorder benefit. And so the link on the right is the report, and they looked at specifically pregnant individuals with substance use disorder who are covered by Medicaid. And just wanted to highlight some of the data outcomes. 1 in 10 pregnant individuals enrolled in Virginia Medicaid had a substance use disorder diagnosis 12 months prior to delivery. Among these individuals, 36% had some type of treatment in the 12 months prior to delivery. Good, but we have a lot of room to grow. And this is a great time to intervene, because usually during pregnancy, that's some incentive to engage in treatment, where if an individual is not pregnant, they may not have that same consideration. Treatment rates for individuals pregnant with opiate use disorder increased considerably, 58% in 2017, compared to 78% of pregnant individuals with an opiate use disorder engaged in treatment in 2018. And then disparities persist in treatment. Black women with a substance use diagnosis were less than half as likely to receive any treatment prior to delivery. And that's around 20% compared to white women enrolled in Medicaid, which was 44%. So again, the data is good. It tells us what we're doing well, but it also gives us opportunities that we need to focus on. And one more slide, and then I will transition this to Laura. Again, more data. This is the prevalence of diagnosis of substance use disorder by member. So Virginia Medicaid members for state fiscal year 2020. And you can see here at the top, you have the percentage with any substance use disorder diagnosis, and then it's broken down to opiate use disorder, alcohol use disorder, cannabis diagnosis, and then a stimulant diagnosis. So you can see here the breakdown is by age group, race, ethnicity, and then pregnant individuals and low-income children. These are 8 categories. And so I thought that would be something you would be interested in. And with that, I will pass it to Laura.
Can I ask a quick question on that, if you don't mind? Is the first number, is it inclusive of the other subcategories, the 6.1? Does that include, does SUD include OUD, AUD, and the other categories? Is it cumulative?
Do you know, I need to go back to the reports. Let me do that to be able to answer correctly.
Sure. I can follow up with you. Right? Thank you.
Thank you.
Thanks.
Thank you, Ashley. All right, so we're going to talk about our utilization dashboard, and Brooke, you can go to the next slide. This is the link. And one of the things that we really wanted to do, of course, is be much more transparent with our data, but also this has been really helpful to our team, because this is the first time we've had access to data like this ourselves. And so ultimately, we use this dashboard probably, I would say I use it probably on a daily basis at this point. And one of the things that really has been really interesting about using the dashboard is that really it's been about bringing up, and sort of thinking about the data, and then what other questions is the data bringing up for us. And there are a lot of questions when you look at the data, and it sort of leads to another question and another question, and really we sort of start to refine what do we really want to see in terms of success for our members. So really this is just a starting point for us, and we use the dashboard certainly to look at concrete data, but to really refine sort of where we want our programs and our policy to go as well. So these are just some of the questions that we ask ourselves when we look at the data. And we're going to take a look at the dashboard as a whole, but then I'm going to give you a couple of examples of sort of looking at specific data and sort of what sort of questions come up while we look at that data. But I know therapeutic day treatment is certainly a hot topic in terms of, you know, what's going on at the school service. It was a robust service pre-pandemic. And sort of what does that data look like now? And we're going to take a look at that when we get to the dashboard. And part of what we want to do for Bravo is obviously we want to reduce the burden on state psychiatric hospitals. And so looking at the current utilization of that service. So what are the demographics of the individuals that receive that service? How many people are receiving that service? What do the trends look like? We want to certainly see, you know, reliance on our inpatient units decrease over time. So certainly we're going to be looking at that as we move forward with Bravo. And then we ask, you know, and then I might ask you guys questions while we're looking at the data. What else, you know, what other questions come up for you guys as we look at it? Certainly we want to see continued expansion of access to our Bravo services. So, you know, the things that we're looking at right now is what is our baseline utilization? And then what do we want to see over time and sort of percentages of increase of utilization of those services over the next year, or the next 5 years. These are the things that we're having conversations about internally. And then we have been, and I'm sure many of you know about the state task force, Safe and Sound Task Force, and we've been a central part of that task force on a daily basis. Dr. Ward and many of our other team members sit on that task force and assist. And so really looking at improving care coordination for youth and foster care and reducing the need for residential services. As many of you know, the majority of the individuals that receive our youth residential services are children in foster care. So I am going to take over sharing, and I'm going to share my screen. You cannot start sharing while the other participants are. Okay. Oh, thank you. All right, let's see if I can make this happen. All right. Hopefully you can see my screen, and hopefully what you're looking at is the dashboard on our website. Hey, thank you. Good. It's probably relatively small. I'll look at increasing the size in just a second. But in order to find the dashboard, you're going to go to, you know, dbas.virginia.gov. You're going to scroll over to where it says data, and we are first on the list, behavioral health, and you're going to scroll over, and it is the first dashboard on the list, and you'll click, and the dashboard will load. I just want to shout out to our Office of Data Analytics and their contractor Optum. This dashboard is processing millions and millions and millions of claims when you guys are clicking on the filters. And it is the fact that it is as fast as it is, I'm very, very impressed considering how many data points get filtered through this dashboard each time. So the dashboard is broken up into 3 different sections or buckets. This is the first section. It's called our member profile. And you can see up here where it was last updated at the beginning of August. And then this is the sort of home screen. It's going to land you on state fiscal year 2022. So this is our first filter, and you can filter by state fiscal year. You can also filter by program, so either managed care or fee for service. And right now our fee for service contractor is Magellan of Virginia. You can filter by service. So all of our services, past and present, since I believe, I want to say, 2017 are on the dashboard. And then you can also filter by age group. The information on this first sort of member profile homepage, there's some information about total amount paid, and this is claims data, average amount paid per member per the service, total members receiving services. So as of right now, In 2022, 305,000 individuals have received a behavioral health service. What I will say is that there are also some caveats to the dashboard, and you'll find those caveats on our footnotes section of the dashboard. Please note that our 2022 data is incomplete. Generally, it takes 6 to 9 months for claims to come from our contractors to our system, and then for us to upload them into our system and get the dashboard updated. So right now, you're looking at limited 2022 data, 2021 data, and the rest of the years are complete. Survey utilization data does include primary diagnosis of substance use disorder. So if you're wanting to look at specific diagnoses and not wanting to look at substance use, or you just want to look at substance use disorder, you'll need to filter, for that category. The residential services, in terms of claims and the money that's being spent on those services, we are only capturing the per diem, so the per day payment that the facilities get, that they claim. Facilities are also allowed to bill outside of that per diem for professional services for those like a medical doctor or a licensed professional, and those claims are not captured on our dashboard. And the same goes for our inpatient services. So the other things that you're looking at on the member profile are, you can see sort of percentage of members receiving services by age group, by ethnicity, and by race. And also what's really cool is that if you hover over each one of these, it will give you the tooltip. It will give you how many members and how many claims were paid. The same for ethnicity and race, and then also gender. And my personal favorite, the primary diagnosis section. So this is, I find this just because I think it's cool. This is what I like to look at in general. And you can see actually in total for 2022, substance-related and addictive disorders, I believe is 1, 2, 3, 4, 5th on the list in terms of prevalence. So definitely something that we're looking at. So I want to look at the next tab is our map, and it's basically a heat map of where services are being provided and where those numbers are. And so you can filter it by state fiscal year. You can also filter it by service. And then you can also hover over each locality, and it will give you the tooltips for each locality. So if we look at, let's look at 2021 data, and we look at Chesterfield because that is where I live, you can see that a little over 11,000 members received behavioral health service in 2021, and around $53 million were spent on those behavioral health services. And if you want to filter it by service, you can do that as well. The next tab is our expenditures tab. So it really helps us to look at trends in terms of claims and also number of members receiving service. And out of all the tabs, you probably use this one the most, but that's just me. I'm looking forward to hearing everybody's feedback on what they feel like is most helpful. Again, you can filter by program, service, you can filter by diagnosis on this section, and the members each group. So I am going to keep it here for a second, and we're going to look at TDT data pre-pandemic, and then I don't really want to say post-pandemic because we're really not in post-pandemic times. So we're going to look at both fee-for-service and managed care because both of those programs pay for therapeutic day treatment services. We're going to filter just for therapeutic day treatment, and I'm going to go all the way down here and click this and click apply. And then just because there can be errors in billing and claims, I'm going to filter by age because the service is only for individuals below the age of 21. And then we're going to look at it by fiscal year. So you can see where we are sort of in 2019. Total claims paid $174 million, around 19,000 youth received that service. And the average cost per member was around $9,000. And then you can see sort of this sharp drop off as we go into the pandemic, and that sort of continues. And then right now we're seeing a slight bump up as schools get back into the swing of things this year. And that's sort of where we are with this service. And questions before I move on to the next service.
This is Emily again, and so thanks for showing this TDT service here. I played around with the dashboard a little bit before this meeting and focused on TDT.
Yeah.
That is the service that I know would be at least a trend over time that was dedicated to kids. So just pointing out here that I think, from my perspective as an advocate, what I see here is a major decline in investment in mental health services for kids, because we aren't seeing the service being offered for kids in school. I'm looking at that on a pure numbers perspective, and
Yes.
from the dollar figure of what we were putting into the system around kids' mental health prior to the pandemic is about $150 million delta here. So, for me, what that raises is a number of questions about TDT and what is being made up as the differences in terms of children's mental health services delivered primarily through school-based settings now, and how we can make up the difference or right size the services that were needed. If kids' mental health services are being met outside of TDT, how can we reinvest in those services at the level that TDT was being offered before? Or if our schools are having problems trying to meet the goals of TDT that were around behavioral issues in the classroom and focusing on teachers, how can some of the investments go into that direction of working with schools and equipping teachers to have the resources that they need? So for me, it really brings up a number of questions, and that the solutions might really rest outside of DMAS totally, and be some looks at the overall system of mental health services for kids, how the schools come into play. But for me, I just want to keep that. I think it was about 150 million, 125 million in front of folks to know, like, that was our benchmark of what services were being offered to kids. And I think they still deserve to have that level of service. So wherever we go with additional investments, I think we need to keep that in mind. Like, that is what we used to pay to help kids meet their mental health needs.
So, Emily, I'm really glad you brought that up, because actually that goes into sort of my next example of what I want to talk about, because I think you bring up some really good questions that we certainly have grappled with internally, during this time, in terms of really, of course, wanting to support all of our members, and that this service was just not a viable service, during the height of the pandemic. And, what services are kids going to get? Are they getting another different service? Was this even the right service being provided in the first place is also a question we ask ourselves. And so the next thing I want to look at in terms of, and of course, these are just questions, these are just theories about sort of potentially where some of that activity sort of shifted during the pandemic. So if we look at, we're going to look at intensive in-home here for a second. And then we're also going to look at, in addition, our behavioral therapy program. And we're going to look at, so this is sort of over time, when you look at those programs, and you see that, they really are sort of studying themselves, and really did not have the massive drop that TDT had. And, I think one of our theories is that, a lot of kids went into one of these two services. If you just look at behavior therapy, you can see that it steadily increased and significantly actually during the pandemic in terms of the amount of members receiving it, which is this orange line, but also the amount of claims that are coming in for that service. So I think that's certainly one of our theories. It's not necessarily correlated in any way, shape, or form, but we're definitely looking at those things because, of course, we would agree. We certainly want, all of our members to be getting the right, appropriate service. If we look at outpatient during that time, and we're just going to look at outpatient psychotherapy, you can also see a huge increase in outpatient during the pandemic as well. So, ultimately, is every single one of those members receiving the same type of service they were pre-pandemic? No, they're not. But I think we are seeing trends where other services are growing even quicker than we even anticipated them growing. So I do think that our system is attempting as much as possible to get those, use the services that they need.
I have a quick question, it's Freddie Mejia. So looking back at the TDT data, the average cost per member is what's I'm finding interesting, right? Because theoretically, maybe that shouldn't shift too much. But it looks like a massive decrease in terms of the people who are, the children who are getting these services. There's a lot less cost per child. So it seems like in 2019, it was 9,000 average cost, and a couple of years before that, and then it just drops and still hasn't really recovered much. So I'm just kind of interested in terms of why that might be.
Well, again, I mean, I think, yeah.
I was just thinking with school-based services was one of the main things.
Can you all hear me? It's Dr. Ward making my best attempt.
Yeah.
You can hear me? Okay. So one thing I want to note, around this conversation of kind of equity and investment is that I would agree that we want to be looking at making sure that we are making the most robust and appropriately distributed investment in children's services as possible, and that should be our system-wide priority. I want to also be mindful that while DMAS is the primary payer, the predominant payer of behavioral health services for kids, there are other payers in play. And so looking at our utilization alone in a sea and tides of changing pandemic utilization patterns, that it's important that we work towards the ability to look across the whole system and how children access services and what funding they use to access them. Because there's a bit of apples and oranges there, and we want to make sure that we're making the right investments in the right spot. What we see in terms of that cost, the last question about cost per care per kid, there are significant and acknowledged issues around the rate and unit structure of therapeutic date treatment that we've been in discussion with providers for years at this point. And, essentially one of the biggest issues with sustaining that service has been this quandary around the rate and unit structure, because the service was essentially built as a group-based service. So the rate is a group-based service and operates under the assumption that you have children in a group offering that service. So the rate for each individual is lower because the assumption is like when you build a PHP or an IOP or any kind of group day treatment, that the kids are predominantly together in a group. Well, the business models that this rate and unit structure for many, many, many years ago set providers up for was to need to bill max units to make it a financially sustainable service, in particular under the inflation context that we're in now and the workforce context we're in. So if we think pragmatically about what's best for kids and we think about the dependency on needing max units just to have enough of a rate to pay your staff, that means kids being pulled out of the classroom for the entire day of school and not receiving any educational services. So there are just some really pragmatic issues that need to be dug into and solved around that rate and unit structure to allow for flexibility where that cost of care may look different. If we're able to have the opportunity to rework this together as joint stakeholders with DOE, with providers, and with best practice around school-based services, because we need to have a rate and unit structure and a diversity of services that range from screening, prevention, all the way up through something as intensive as classroom pullouts or intensive behavioral supports in classrooms. We need to have that all laid out, and those services need to be defined appropriately on a financial scale that's going to sustain that workforce in the school. And that's, that we're far off from that, but that is the vision of where we would like to go. And right now, given the state plan that we have and the authority that we have under the GA, we have TDT to work with. So, we continue to problem solve, and we're having a meeting coming up with a whole large group of providers to discuss their conundrum around TDT coming into this fall. But we hope that this will not be a sustained issue. We hope that we'll have the opportunity to at least remediate that rate and unit issue within the larger seeking of enhancement of school-based services.
Can I ask one quick question? This is Susan Brown again. I know it's a very small percentage of the overall pediatric population, but the 0 to 4 age group that you have listed here, I'm assuming that the 0 to 3s are your Part C kids and I know early intervention services in Virginia fall under DBH. So can you parse out what services, because virtually all early intervention services went to 0 in 2020. You can't do virtual appointments with a 6-month-old, right? So so that was one area that I know we have a really large population of kids in this Commonwealth who did not get served for at least a year and a half. And I don't know how that plays into the numbers or if you're able to pull that out in a different way. They're falling under DBH, but they're not really getting behavioral or mental health services for the most part.
There are certainly probably things we can do to play with the dashboard and looking at it. And Laura, if while I'm talking, you want to do any kind of filtering or just kind of hypothesizing with looking at that age group, I think that would be probably pretty interesting. This is definitely an age group where there is much work to be done in general across Medicaid programs in bolstering our ability to serve caregivers and children dyadically, and our ability to reimburse appropriately for those dyadic services in order to screen. And I would encourage you, there are 2 new guidance documents from CMS that came out, one on the 18th of this last month and one on the 22nd. And the one on the 22nd, I believe, is the one that's called like leveraging CHIP and Medicaid for children, transforming children's mental health services. There are some really exciting nuggets in that guidance letter related to 0 to 3, Sandra. They got me very pumped up. One is about encouragement of states formally converting over and adopting the diagnostic standards for 0 to 3. And the second one, which I think is particularly interesting, is encouraging states to explore moving in California's direction of removing diagnostic requirements for outpatient services and that 0 to 3 population. To allow for greater ability to do prevention services and kind of recovery or wellness oriented services on an outpatient basis. So I know that's something as a practicing psychologist that we have been interested in for years. And so it's exciting to see CMS recognizing those pieces for prevention coming together, particularly for caregivers and their young children for infant mental health and doing, really early childhood intervention.
This is Emily. I don't want to speak too much, but just to add one thought here, as you're talking about early childhood and therapeutic day treatment, one thing I know from experience is that other states define TDT services as sort of their own mix of services, and we have that ability to have some flexibility in how we define that. Missouri, for example, pays for therapeutic childcare programs as part of their TDT services. So just thinking about that, potentially that model moving forward, not only of therapeutic in the early childhood programs, but maybe in the school-based settings too, where you have mental health consultants and professionals in classrooms that are also funded by some of this TDT services. I know at least one state, Missouri, does it in the childcare space, but there's probably more to look at that too in the K-12 space too.
Thank you, Emily. I'd love to read more about that and their model. So we can hopefully connect around that. Laura, have you been doing some fiddling?
I have. Yes, we're currently looking at expenditures across state fiscal years for the 0 to 4 age group. It looks like they've, of course, increased slightly over time. And actually right now, 2022 is majorly increased from 2021. So, and we're not even done with 2022, and the claims are behind in terms of getting into the dashboard. So 2022 is looking real interesting in terms of lots more utilization of behavioral health services for that age group.
I was born in the pandemic and we struggled too.
All right, I hope I am mindful of time, and I could talk about the dashboard all day long, and I think Dr. Ward probably could too. But if anybody has wants to talk about what they find on the dashboard or have any feedback, we are looking probably sometime. I'm not going to put our Office of Data Analytics on the timeline, but most likely sometime next year, looking at our behavioral health dashboard 2.0, which will most likely include some additional filtering and some additional categories as we move forward with getting all of this up and running. But we're excited to see what you guys find, and happy to talk about it. Please reach out. So I'm going to hand it back over to Hope.
Thank you, guys. Thanks, all of you. So I think for our next segment here, we actually have Dr. Boutwell here in the room with us, the director of our Office of Quality and Population Health, and she's going to talk a little bit about another piece of the dashboard. And we're going to, Brooke, if you could reload the slide deck, I think that Dr. Boutwell is going to be working from some slides.
While Brooke is pulling those up, good afternoon. Laura Boutwell, I'm the Division Director for the Office of Quality and Population Health. It's good. I've met some of you in person and most of you virtually over the last few years, but it's nice to see you all. And we're going to talk a little bit about Hedis, dive in a little bit more about what Hedis as a data set is, talk about the dashboards we have currently online and our future plans for additional dashboards under that quality system. So I won't jump too far ahead until we can get the slides up. Great, thank you, Brooke, for getting these going. We'll just get down to,
I think it's slide 42, Brooke.
Thanks, Hope. All right, great. We can advance to the next slide. and I just went over this, so we can probably advance to the next one. To start out, what is HEDIS? And I know I've either myself and even my predecessor, Tanya Williams, in this role has presented HEDIS information to this group in the past. But I wanted to take a moment to step back and actually explain what HEDIS is, because I think that's important to the context of some of the questions we received in the past. So HEDIS stands for the Healthcare Effectiveness Data and Information Set. It is one of the most widely used set of performance measures in the healthcare industry. And the measures, and this is a key piece that I wanted to say, the measures are actually developed and owned by the National Committee for Quality Assurance. They are the data stewards and they set the standards. They are an independent organization that works to improve healthcare quality through the administration of evidence-based standards, measures, programs, and accreditation. Measure domains cover a wide variety of topic areas, including prevention and screening, chronic conditions, behavioral health, overuse and appropriate use of care, and access and availability of care. And in Virginia, and for our managed care organizations, are actually required to be accredited by NCQA. And therefore, they have to report these HEDIS measures annually as a part of that accreditation process. And we can move to the next slide. So there is actually a secondary step that happens as these measures are not just kind of, exported from a system and submitted to the state or to NCQA. There's actually a formal auditing process that occurs for these measures. And in fact, they not only have to be audited, they have to be audited by a licensed and accredited organization by NCQA. And they are not considered a HEDIS rate unless they are actually audited by that certified HEDIS auditor. And so these audits are done for a variety of reasons, but they are included to make sure the systems that are accurately capturing data, that the rates themselves are valid, accurate, and reliable, and they ensure comparability to national benchmarks that exist. And so in our state in Virginia, each of the MCOs will work with a certified HEDIS compliance auditor to audit and verify the measures that we get. They are then submitted in a locked file to NCQA and to DMAS. And so this is where this information comes from. And so what we wanted to do is to take these HEDIS measures and to transform them into a public-facing dashboard, very similar in concept to what we just saw for the Behavioral Health Utilization Dashboard. So we can go to the next slide. We wanted to do this in order to demonstrate the quality of care for our members, to provide transparency, and to demonstrate accountability. Next slide. So we did start this, and the dashboard that is currently available is for what we call measurement year, or MY 2019, also referred to as HEDIS 2020. This was created as the baseline of reporting for the following reasons. Back when we started to work on this dashboard prior to COVID, but it was post the implementation of the CCC Plus program, post Medicaid expansion, and post Medallion 4.0 procurement. We do plan on updating the dashboard annually, and we will be maintaining 2019 as a baseline year for now. There's an asterisk here. We are definitely considering what it means to actually have comparisons to measuring the year 2019. We hope to, just as an aside here, to have measurement year 2020 up by the end of the year, and then we will actually be catching up because there's been some delays due to the pandemic, data collection and review to get a measurement year 2021 in early 2023, so we can catch up the whole cycle for the dashboard. Next slide. And so I'm actually going through a static version of something pretty much what we kind of went through earlier. The data tab that Laura Reed pulled down to get to the behavioral health utilization dashboard is actually the same tab that you can use to get to the managed care HEDIS dashboard. When you do click on that the data tab up at the top, it will bring you to an opening screen that gives a little bit of a background of what the dashboard might be tied to. So I do want to call attention, we do actually have national benchmarks in the dashboard. Those are based on the national 50th percentile, which is from the MCO contracts. That is the minimum that the MCOs are expected to maintain for their performance in some of this work. And it also is in alignment with our 2020 to 2022 quality strategy. And I'm going to make a brief plug for this. We are updating for our 2023 to 2025 quality strategy, and we'll be soliciting for public comment here in the fall. So we'll definitely make sure to reach out to you all as well. So Next slide. So when you scroll down, when you're on that same page, that was the top part, and you're now on the same page, you'll actually be able to look at the different domains of the HEDIS measures and click on each of these individual areas. As we went over before, you can click on access, you can click on preventative care, substance use monitoring, but we're just going to do a brief demo of the behavioral health tab. So if you go to the next slide, which would functionally be clicking on the next piece, and I apologize that it was this is care for children and adolescents, not the behavioral health one, but we'll start with it. We'll go with this one. But this does include for children, and actually includes the behavioral health, some of the behavioral health measures here. So you can see that each one of these are measures that have different domains under the domain of care for children and adolescents. These are all independent HEDIS measures. And then you can click on each one to move into the next section. So we can move to the next slide. So this is an example of follow-up care for children prescribed ADHD medication, the initiation phase for HEDIS 2020. Again, that's measurement year 2019. So this actually provides an MCO level breakdown of each of the performances of our managed care organizations, combined medallion and CCC plus, with one exception having to do with accreditation, which is United. This will be corrected moving forward. This is going to be corrected in years moving forward, starting in measurement year 2020, but it has to do with their accreditation status. But for the most part, the rest are combined between Medallion 4 and CCC plus. You will see that the MCO average is at the very end, so the second from the far right, and then the 50th percentile is also all on that screen. At the bottom, you will see that there's the measure definition from NCQA of what this measure is measuring. And for here, it's the percentage of members 6 to 12 years of age. And I'm not going to read all of that, but you can read through each one, and each one of the measure that you click on will have the independent measure definition with it. Right now, this is as granular as this dashboard gets. When we talk about moving forward as far as annual updates, we hope to include year-over-year trending for at least 3 years running over time as we move forward, as well as keeping the most current information as we move forward. So next slide. Do we have another one? Yes, next slide, please. Oh, yes. Oh, previous. Sorry, it is different. Oh.
Awesome.
Well, thank you, Brooke. I appreciate it. Okay. Perfect. Thank you. So this is another one of the measures that we're selecting, which is the use of first-line psychosocial care for children and adolescents on antipsychotics, their total measure. And again, you'll see how the MCOs are broken down individually for these rates. There's the MCO average for Virginia, as well as the national 50th percentile. And so this one, you can see the different results. The colors are consistent across for each of the MCOs and align with some of our new visibility and access requirements to make sure that the colors try to meet those standards. And so that is what we do for each one of the measures. I hope you are able to click on that dashboard if you have not been able to take a look at that in the past. So I'm going to stop here because this is the end of the dashboard demonstration to answer any questions or to talk through anything you've seen today.
So we're supposed to be measuring it according to the 50th percentile, like they should all be at least that high.
That is the expectations in the contracts, yes.
I just want to make one comment. I was actually the pediatric co-chair of the CQMC for the last 2 years that I was with Anthem. So I do know that there are some new measures coming out, updated measures, some more behavioral. We really focused on behavioral health measures because we thought that that was really important. There are other HEDIS measures like first line for ear infections and stuff like that. But I think, just sort of tagging on to the conversation earlier today, we're going to be seeing more focus on behavioral health screening as well as care. So
That is great, an excellent point. There's a lot of things happening on the end. And so I will actually, to piggyback off of that, in addition, one thing that's always been a bit of a limitation with the HEDIS measure is that it's on this kind of very high level MCO level. And that is, but moving forward, NCQA is now instituting and starting to pilot requirements for race and ethnicity stratifications for these measures. And so that with that means that they will be audited, certified measures submitted as part of the MCO's NCQA accreditation requirement will include those stratifications, which will be a really powerful tool to have that certified data coming into the state to be able to use, in addition to a lot of the work that's gone in to expand and look at what are meaningful behavioral health measures to include in HEDIS. And we're very excited to see those changes moving forward. Thank you. Any other questions on HEDIS and the dashboard? All right, then I'm the next couple slides is a very brief discussion related to one of the core focus areas of the Office of Quality and Population Health, and that is the oversight of our External Quality Review Organization, or EQRO, which is currently Health Services Advisory Group, or HSAG. And we are required by the federal regulation to contract with an external quality review organization, and they are required to conduct certain mandatory and optional activities as outlined in the federal regulation citation, but to review both MCO and states' commitment to the quality and the work that's being done. So we can go to the next slide to dive in a little bit deeper. So I didn't go into this is a brief snapshot of specific activities that the EQRO does in partnership with DMAS that tie in with behavioral health and children that we have some oversight. Now, one you will probably recognize that since we actually will be presenting in one of the Q1 or Q2 meetings on what was formerly known as the Birth Outcomes Focus Study, will now be the Medicaid and Children's Health Insurance Program, CHIP, Maternal and Child Health Focus Study. We also do the Child Welfare Focus Study. That used to be the foster care study, but we actually expanded it to include all children touched by the child welfare system. That includes measure breakdowns and specific looking at behavioral health outcomes in those activities. We worked with Ashley Harrell's team and Dr. Ward on developing arts measures with our EQRO. We have the EQR annual technical reports, which are actually program level detailed required reports that our EQRO puts together that outline all of the quality activities that are done on a program level that are required for reporting to CMS. And we also do additional measure validation activities to look at different measures. We do our performance withhold program, which is under the Office of Value-Based Purchasing. We help support that activity, and as well as the quality strategy that I mentioned previously. This is a very high level. I know that you all love the details, and I know that for some of these, we actually have, like we said, a specific focus time to go into the details, so I didn't want to go into all of that here. But this is just a number of the different activities that the EQRO does to support behavioral health and children for Medicaid. So I think the next slide is, yes, questions. So I'm gonna stop there and ask to see if anybody has any additional questions. I was booking it, I guess. So
No, thank you so much. I was just going to say very useful. I was able to make a ton of notes. Thank you so much.
Great. And we as even Laura said, if you all are using these dashboards and you think there might be some specific unique way or interesting way that you wanted us to present this information online that would be of help to you or your organizations, please reach out to into the Office of Quality box, or if you're not one haven't received an email from me in some capacity or other, you're also welcome to email me. I'm happy to receive that feedback, because we want this to be a tool for everyone and to continue to transform our quality data to be more accessible to everyone, members, stakeholders, and teams. So.
I have a quick question.
Yeah.
So the race ethnicity data, so that is scheduled to go online, like you said, soon. When does the publicly available reports also have a lag, right? So
They do.
it might be a couple of years until we actually see those.
So we currently, this year, I believe there are 6 measures that are going to be required to be reported by the MCOs to have race and ethnicity standards. And I can get those specific measures to you as a follow-up. And moving forward, there will be more to be included in that. So for this year, data collection, we're looking at the 1 to 2 year lag as we move forward for collection. So there is some. We are working internally to see what we can do to look at this in-house to kind of monitor more real time. But again, we're limited by the 6 to 9 month lag, as well as the fact that they are not going to be technically certified results. They're just going to be our own internal interpretation. So
Someone that's been waiting for census data for like 3 years now. I totally get it.
And for Dig, it's wait for like another 10, so.
Yeah, really.
About the race ethnicity. Is it, this might be a silly question, but does it come from at the provider level identifies race ethnicity, or is it tagged to what DMAS collects on the application? Where does the race ethnicity get identified as the marker that then later on populates all the great reports are about to come? Not too fast.
that is a really great question. So for DMAS, that information comes in the application process, and that's the source of truth. The MCOs do collect additional data. They have in fact probably ongoing conversations and are able to update that information or to make sure it, and providers are able to do that. And so one of the conversations I've actually had with NCQA is trying to understand how they're going to audit this information, because some states are required to stick with, what their Department of Social Services, or whoever's collecting the eligibility data there, an application, they have to stick to that. So that's kind of an ongoing conversation. I'm still trying to get more details on, but I'd be happy to come back and share more information, because
it's a challenge.
It is a challenge. How do we ensure that is the most accurate information to provide? Absolutely. Well, if there are no other questions, I'll turn it back over to you, Hope. Thank you all for your time today.
No problem. Thank you so much for everyone from DMAS for all the very in-depth information we've gotten today. Really appreciate it. As always, the slides will go out after the meeting, so the links and those things will all be included. But if there's any particular information that was mentioned today that doesn't go out in the follow-up meeting, let us know and we'll get it out to you. So I know there are some additional reports and things mentioned. So let us know if there's something you've forgotten to include. The last agenda item that we have is just planning our agenda for our December 8th meeting. When we first kind of plotted out the year a little bit, left this one kind of open and flexible to what came up during the course of the year, what we wanted to include. So I've kind of kept a running list of things that have been mentioned, and I will just go through that. And then we kind of can just open it up for conversation into what, obviously it's a very long list, and we certainly will not be able to get to it all in one meeting. But just, I figured it'd be a good place to start at least. So Natalie has asked several times, and other people have mentioned just more detailed information on vaccine data and a follow-up on the vaccine presentation that we had a couple meetings ago. Report from the Well Child Affinity Group, an update on Cardinal Care, which I'll note doesn't go live until January, so it might be valuable to pull that one off until it actually goes into effect, or if you want to know about it beforehand. And Cardinal Care is the merging of our Medallion 4.0 and our CCC Plus MCO contracts. So we're going from 1 to 2, we're going back to 1 MCO program starting in January. Follow up on some of the maternal child health initiatives that have gone into effect this year: 12-month postpartum, famous prenatal, a general maternal health overview. Again, if we wanted to wait until early next year for the report, the CHIPAC child maternal health report that was mentioned as an EPR strategy, we could hold that one off. Unwinding may or may not have a timeline for that, so who knows? A presentation from an external partner on coverage options for undocumented children and other children who are currently ineligible for various types of coverage. And then other presentations that we've had that if there was need or want for follow-up included emergency Medicaid changes, school-based services, the evolution initiative at DSS, which I believe is on hold right now, if I'm correct. And then there was that whole list of EQR activities if anyone wanted a deeper dive on any of those. So I know that was a long list, but for others, those are just things I had kind of noted throughout the previous 3 meetings that were mentioned.
Would it make sense at that time period after agency submissions are public and DMAS might be a little bit more willing to speak publicly on those to kind of just have a brief overview of anything that kind of touches on Chip? I don't want to
Children's budget priorities.
budget request, right? Yeah. It might, I don't know, like it might be too long. So I always want to be sensitive on time. But if I don't know, just like if there's some highlights. Yeah, that's right.
Could include, so in your packet today was just kind of highlight of the children's health budget initiative that have recently gone into effect. We could certainly do something like this just to include for member information, but not necessarily have a whole presentation on it.
I'm just thinking the December meeting, a lot of the time, the timing is just kind of weird. The governor's budget isn't out yet.
And it's kind of weird because it's also, it's an interesting time to know what's happening. I mean, you have open enrollment and how that impacts. I don't know, in some of the things that you were reading off, there could be a little theme that you have, because you have some of the new initiatives that came in, including some of the initiatives like for famous moms expansion, and then also maybe thinking about bringing in a speaker that can talk about initiatives that have been successful in other states, you know, to expand coverage to all kids, which was on your list. So you could have kind of like an immigrant theme to kind of just to give a sense of maybe we could get a report on, you know, what do we know in terms of immigrant children within the Commonwealth and what's happening and what's the state of play. And then also, you know, how these different initiatives have played a role. And then, you know, maybe getting a speaker or two, especially since we can bring in speakers through Zoom, having, you know, somebody from a state that actually successfully implemented, you know, 1 or 2 states, that might be interesting to hear from their point of view, what it's looked like, what they've, you know, I don't know, like a little thing. And we will have a public charge rule by then, I promise, I hope. That might be of interest too, to hear how that's playing out. Probably Friday at 5. Yes. Yeah, that seems right.
That would still like last Thursday, right? Maybe we can do that other time.
Back to my just to go back to my request, like I think the member information sounds good. Like something like this makes sense. I just want to make sure that everyone like is aware of like things that possibly could go into the budget. Obviously, would be, so, yeah.
Well, can they even create that if the governor hasn't announced his budget?
The DMAS.
Oh,
So from the agency, and DSS, if there's a bunch, but like from the agency, there's just packages, like what's been requested.
I mean, I have something not for next meeting, but at some point in the future meetings, I really would want us to follow up on the, you know, trying to help with reducing the behavioral health hospitalizations, how that's disproportionately coming from children in our foster care system. You know, maybe I don't need another PowerPoint presentation, but I would love a discussion. And if we need to pull in the right people from DSS to be in the room, like, because I know that I personally, even though I'm in all the meetings, I haven't heard a family first update in a while, so I don't really know where that's going. And I'm sure they're talking about it. I'm sure it's coordinated, but I would love, I think an update on that would be really helpful.
I mean, I feel like that would be family first, but also the Safe and Sound Task Force, right?
Yeah.
Are there other things like that that would need to be?
Nice knowing you. I'm just kidding. I'm kidding. I will be coming.
You say that.
I say that.
I won't judge you, Shelley, okay? In fact, I want that for you.
I'll see you on the screen.
You better be in your pajamas. I want you to look so comfortable that I get it.
Well, I'll have to be in my office if I'm not. If I'm not.
Does anyone have any other thoughts? Obviously, we're open. I will say, again, because of some changes, we have to get a request for presentations in about 2 months before the meeting. So executive subcommittee will meet in about a month. So if you have other thoughts or things in the next month, shoot me an email. If you have thoughts after that, it'll probably just be for a 2023 meeting, which is absolutely wonderful as well. That's kind of the timeline for working with.
Because the unwinding piece is so important, but like we just won't like really know until like.
Well, no, it won't expire. Yeah.
Right, it will happen eventually.
Based on all the rules that came out yesterday, I'm highly doubting it would end in January, but that's just conjecture. So proposed rules. Well, we will open up for public comment. Then there's no one in the room, but I don't know if anyone online would like to submit public comment for the committee. Finish that.